keeping your baby safe.
It's busy, busy, busy.
Tonight, On Call. Funding for On Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. In South Dakota, 7 children die for every 1,000 that are born. We are ranked 15th worst for infant mortality in the U.S. What can we do now to improve the outcomes for our infants? Keeping your baby safe. On Call tonight.
This is dedicated to the one I love. This is dedicated to the one I love. This is dedicated.
Hello and welcome to On Call Television. To study infant mortality is said to be the gold standard for measuring the health of a population. In 1911, a leading pediatrician stated, "The country which first recognizes its responsibilities to the child will receive the recognition of the world as being the foremost civilized nation." In recent years, it's become clear to South Dakota leaders that the above statement goes for states as well, and so Governor Daugaard appointed a task force on infant mortality. His wife, First Lady Linda Daugaard, chairs this important group.
80 babies, healthy babies, die every year in the state of South Dakota, and we just found that to be a staggering statistic. As we started looking at it, we were higher than any state around us, and that was the first red flag that Dennis started seeing. You know, with the states of North Dakota, Minnesota, Iowa, Nebraska, we just stood out, you know, higher than any of those states. Our numbers were falling through the 60s, 70s, 80s, and then in 2000, they just really started creeping back up. So I think there wasn't not much attention to it at that point. So many people had said, we just need to start tackling this. In May of 2011, then we started the Infant Mortality Task Force and got together a group of great professionals and learned more about it and started tackling the problem. We found out that a large percentage of moms smoke while they're pregnant. Another thing, not enough prenatal care in the first trimester. And then the third component of that was sleep, safe sleep. Once the child came home, did they have a safe place or a safe environment to sleep? So those 3 things is what we really looked at. The one thing you could do right now to help is to, if you're a grandparent, to make sure that your son or daughter knows what safe sleep is and what it should look like. If you're a parent, make sure you find out what safe sleep practices are and really look into that, and also pass that on to daycares or any kind of provider that you have or babysitters that come into your house. One cool program that's come out of this too, it's a program called TEXT, T-E-X-T, and then the number 4 and then baby. A mom can put this on her phone and then she'll get weekly updates on what she puts in her when the baby's due, and then the mom will get weekly updates on what the baby looks like. You know, it's the size of an orange or it's the size of a grapefruit or whatever, and then what the mom should be doing, getting enough water, getting exercise, getting enough sleep, and things like that.
We are at On Call Television and Healing Words Foundation applaud this effort and have responded by inviting 2 members of this task force to be on our show tonight. Dr. Kim McKay, MD, OBGYN at Avera, and Dr. Bonny Specker, PhD, epidemiologist at South Dakota State University. Welcome, the 2 of you.
Yeah. Thank you.
So the task force finished its job over a couple years of work on 2011, is that right?
That's correct.
And so there's been some of the recommendations. I mean, and she outlined those major things, did she not? I mean, tell us a little bit more about Kim.
So the task force, it was kind of daunting to look at all of the variables that go into what causes a baby to die, but our take home was what can we control? Because there's a lot of things that we can't control. There's a lot of things that are dependent on funding, and one of the main things that we took away is our babies in a safe sleep environment, and we used a model from North Dakota to come up with what we call the Cribs for Kids program, so that we can identify parents who don't have a safe sleep environment for their child, and then in our own respective hospitals we took back how to educate our patients on safe sleep habits for their babies. So that's what we can do on the medical end. I think you can.
And just to finish that safe sleep habits, it's 2 things, isn't it? It's one that the baby lays on his or her back, not on belly like we used to think when I was going to medical school. And the other is not sleeping in the bed with mom and dad.
Well,
And a clean crib.
And a clean crib. So those little crib bumpers
Yeah.
that are so beautiful and the most expensive, those never they should never be near your child. And so our Cribs for Kids program is, for people who need them, we provide a pack and play that is, it looks like, it's very basic, but it's important for families where maybe they would be bed sharing otherwise.
Right. And then there was this special, this is a Brookings Health System. You might notice the logo of the Brookings Health System.
Yeah.
But tell me about this little wraparound thing, this swaddle.
So I'm a new parent. I have 2 children, a 3-year-old and a 1-year-old, and both of them slept in this. This is actually for the tiny babies, and it's a swaddle. And this allows you to put your baby into a warm, cover them up and keep them warm, but to do it without blankets getting loose and
so they don't need
around
blankets.
their face. So they don't need blankets with
Because
this.
blankets will
get up
sometimes
around the face.
suffocate the little baby.
Or if you have a blanket and baby then starts turning over from back to front, which is typically where they'll start rolling, and then if they would get that blanket in their face, this really prevents this. This actually provides a swaddle if you're into swaddling your babies either under the arms or over, and then as they get bigger, they make bigger sizes of sleep sacks for kids too.
And do you swaddle your babies?
I do.
I mean, swaddling means that you're basically tying them down a little bit.
You can swaddle them for a while, but I mean, typically by swaddling, it means, putting them in this swaddling when they're tiny, where you keep their fists, close to their face and their arms tight, and they're not going to tolerate that. They start breaking out of it. But this is a nice transition, and actually my little 3-year-old still likes to sleep in his. They make him feel comfy, and he just sleeps in his. So. It makes you feel better as a parent. So that's another thing. Actually, Brookings is doing a good job of supplying those and getting people started with it. Mm-hmm.
Now, Bonny, you're an epidemiologist here, and tell us your part in this South Dakota Governor's Task Force.
Well, I worked with Lon, the state epidemiologist, and looked at a lot of the data. We did a lot with the National Children's Study that related to maternal child health, so I was familiar with that area.
You were the director of the National Children's Study for South Dakota. Well, one of the 6 in the country, right? So this was a real coup to get there.
One pilot tested it, but...
And it was Lon Keitlinger, the state epidemiologist that you were working with.
Right, and other members of the maternal and child health department. But I think the Back to Sleep was a really good program. The SIDS rate in South Dakota,
SIDS is what?
Historically, the sudden infant death syndrome.
So kids between what age and what age?
Peaks at 2 months, about.
Yep, decreases after.
And so, I mean, it happens suddenly. They're gone. You go in and they're gone. And then, of course, there's the terrible pain of the loss of the child, and then the guilt of what did I do wrong? And we see that SIDS this is to prevent SIDS,
Right.
sudden infant death syndrome.
Right.
So, and
It's also to prevent accidents in infancy, and one of the biggest accidents that occurs in an infant is sort of suffocation and strangulation from,
blankets.
from bad sleep situations. So this, I think, has improving not only the SIDS rate, but also the accident rate in young infants as well.
So, well, let's talk a little bit about who you are. I mean, Bonnie, tell me a little bit. I know that you are an epidemiologist, and I know you're an OBGYN, but before we dive into that, I would invite you to call in your questions at 1-888-376-6225, or visit us on oncalltelevision.com and click on the email a question button. We need your questions. They're very important to us, so give us a call, 1-888-376-6225. So, I mean, you're from where originally? Where'd you come from anyway, Bonnie?
I'm an Army brat, so.
You were from everywhere.
Yeah, and spent a lot of my adult life in Cincinnati, went to graduate school there, came to South Dakota in 1997, great place to raise kids.
Yeah, it is. What drew you here? Was that, I mean.
The winters.
And the winter drew you here.
I spent about a third of my life in the South Pacific, lived in Minnesota, loved Minnesota winters, and thought I'd like South Dakota winters. I'm
thinking South Pacific again now. But you know, and I'll say it pretty clearly, you're one of the greatest researchers that we have, that I've ever dealt with, and that you're the premium SDSU researcher.
Thanks.
And
I'm not sure about that, but we work hard.
You work
hard. We
hard.
have good people.
And you get results. We really appreciate you
Thanks.
here. Thank you. So tell us about you.
I'm
Kim.
from Belfouche. I'm a West River kid.
So where did you go to undergraduate?
So I went to USD. Can I say that?
Well, that's where I went.
I know, I went to USD. And then I went to med school at USD. And then I did residency in OBGYN at University of Kansas in Wichita. And then I came back home.
And you have an identical twin.
I do.
And what does she do?
She's an internist.
Like I am.
Yeah, her specialty is now patient quality and safety as it relates to the EMR. So she's got a little bit different hat now.
Yeah.
She was the smart twin.
She was the smart one?
Yeah.
She had more oxygen during that delivery?
Yeah, apparently. I was twin B. I was number 2. I was number 2.
And you were Miss South Dakota?
Oh, good. You brought that
I'm
up.
glad
I
to bring
was.
that up.
I know.
That's
I was.
very interesting.
But you know, Miss South Dakota paid for a lot of school for me.
That was a great
Miss
thing
America.
for.
It was, and I think it's you know, it's taught me advocacy, how to be an advocate or how to be involved in your community. And so when I was asked to do like the infant mortality thing, these things come up, and it's just a really great way to, you know, where in South Dakota can you sit down next to Linda Daugaard and have this wonderful conversation about how are we going to make our community better.
Yeah.
So.
And you have the government supporting you on it. I mean, isn't that a great thing? And what a great project.
Yeah.
I can tell you, as a doctor for adults, this whole experience of trying to get ready for tonight's show brought me into reading all sorts of different things that I don't usually read. And, things have changed since.
They have. You know, I teach a prenatal course. It's called Centering Pregnancy, which is a national program that was started out of Colorado. But the intention of it is, you know, prenatal care, but also education. And so we have a section that we do on things that grandparents tell you that you should never do, one of which is, you know, grandparents where you put baby on its stomach or to bed with a bottle, and these are things that now we don't do. And
Oh, yeah, you don't put
we
the
gotta be strong, yeah.
baby-
Always put the baby on
their
the
back.
stomach so that they don't get a flat head.
A flat
That was-
head, so now
Right.
we're having
And that's
issues
wrong.
with that.
That's
Yeah.
wrong. Let's make sure you remember. Wrong.
Don't put 'em on their
I can remember some dear friends of ours adopted a child, and they were so excited and invited us over. And here's this infant, and Joni is a nurse practitioner, pediatric nurse practitioner, and we both said, you know, and you need to lay the baby on her belly, because that was the thing. That, I think 25 years ago. And of course they didn't. They said she didn't like the belly, so she always lay it on her back. And when we learned, changed our mind on that one, What was the difference between belly laying and back laying? Like cut the SIDS rate in half or something?
Yeah.
I think it was more than half.
If you look at the rates in South Dakota, they really dropped a lot.
You know, it's another thing to say. When I was in medical school, the infant mortality rate was the lowest in the nation. And and I might be wrong, but I think it was infant mortality. And it changed. Maybe it was that we gathered the data better. But now in the U.S. we're like 7, and South Dakota we're 8.5 per 1,000 live births.
And
Deaths.
it's gone up since the task force Bonny just shared with me. So.
Yeah, we're not getting a handle on it,
No.
and we don't really know exactly why this happens. But my suspicion is it's the environment of the parents, and including the dad. But we need to talk a little bit more about it. I've got a question. I would like to say thank you to the South Dakota Medical Alliance who has contributed to the Cribs for Kids program. So the Medical Alliance is the spouses of doctors who's been working on this whole effort. And so thank you, Alliance, which is an offshoot of the South Dakota State Medical Association. All right.
A lot of organizations, I think, have gotten on board with the crib.
The crib effort.
Right.
All right. And for Bonny, how do rates of SIDS compare to household income? Income is an issue, and sudden infant death, is there an association?
We haven't looked at that. What we're really looking at is data off the
30
birth
seconds.
certificates. That doesn't exist. But we can look at education level as sort of an indicator.
Yeah.
And we are currently looking at predictors
So
of
we don't know
some of those outcomes.
So we don't know.
We don't know yet.
So I do
We
think
might know nationally.
there's a lot said about poverty and infant death. Do we have any data on that?
Well, it's not just SIDS, but it's also just safe sleep in general. You know, is there access to a crib? I think that's what the crib program is
all about.
providing. Yeah.
All right.
Anyone that needs it can get a crib.
That's
They
right.
can't afford it.
If you can't afford it, just ask.
Right.
It will come your way. As a parent, our worst nightmare is to lose a child. It puts our world in a much different light, and we see needs then that we might overlook otherwise.
Tehlula was born on Mother's Day of 2010. It's May 9th. Everything went fine as far as, you know, her actual pregnancy, delivery, everything. And then it was a Tuesday afternoon, June 29th. My wife and I were both at work. Our daughter was at daycare. You know, everything was fine until, I don't know, it's like 4 o'clock in the afternoon, something like that. Got a phone call that there was something happening at daycare, and I passed an ambulance on my way to the daycare provider and flipped around because I knew it was mine. She fell asleep, and she fell really deeply asleep and just stopped breathing. If the family doesn't have their own plot, they, you know, children are typically stuck in this section, and it spans across a road or whatever out there. But there's a lot of temporary metal gravestone markers that said baby Thompson, baby Johnson, baby Smith, and just a couple dates. My mom and family and we decided to start a foundation to remedy that very specific problem. We raised money, we put on different events. We had a couple softball tournaments, a couple beanbag tournaments, quarter craze. Cubbies did a burger month for us, things like that. So we've raised, you know, quite a lot of money here in Brookings, and we've turned that around into buying 10 by 15 to 18 inch black granite headstones. And then we replaced the temporary markers with the more permanent, kind of a uniform look.
Putting that on the events, you start to remember how you kind of feel that day just because it's in remembrance of her. So there's a lot of stress that sometimes goes with the events, but in the end it all works out. And so it didn't take us very long to start rolling with it and people kind of catching on. And
it was amazing to me how many people that we knew that had lost someone to SIDS. That's, you know, a lot.
And with our foundation, we support anyone that has lost a child, so it doesn't have to be just towards SIDS. So, Some people think it just has to deal with SIDS, but really it's just anybody that's lost a child, whether it's emotional support or financial needs like buying the headstone.
On the ground, we have 135, I think, currently in contact with the Flandreau City and a guy who is working with me trying to get some elders from the tribal cemetery, if anybody knows of anybody that's out there. We're trying to continually widen our reach.
But we've made probably 200. I mean, there's some that we have on hand.
We just felt like they needed another chance to be remembered.
Boy, that's a beautiful story. For more information about the Tehlula Lee Foundation, visit our website for links to the Thompson's webpage, Facebook, and Twitter pages. Well, here it is. People lose a child, and we're looking at all these reasons. You know, we're saying, okay, the reasons a child may die early is because, or, you know, infant mortality may occur because parents didn't do this, parents didn't do that. We could, you know, we need to do these things to improve it. It was, you know, so on and so forth. But then the last thing we want to do is to point a finger and try to blame somebody and try to give them some guilt about this, because...
And I think the majority of infant deaths are not the result of what someone did or didn't do. You know, congenital malformations are high. There's not a lot you can do about that, really. Preterm birth, a lot of the reasons that happens, I mean, maybe prenatal care might help to some extent, but sometimes it just happens, and there's really no, you know, it's not the mother's fault.
The baby comes early, and that's all there is to it. And it happens when women are early in their age. You know, the younger women have a higher risk of preterm birth, but then it happens again as they get older. Or it happens when there's multiple births, like twins. You're a twin, you've had twins. Mm-hmm. So then those children are early or more, or not as ready for and higher at risk for death.
And I think what it comes down to is what can you modify? Whatever you're given in terms of if you have a preterm delivery, which can be very dependent on if you have, you know, kidney infection or if you have to have surgery, or there's a lot of things that occur in the context of pregnancy. That's why we have prenatal care. But, you know, once baby's out, then it becomes about what do you have control over and what can you modify.
I think that prenatal care, I mean, you provide a ton of that in your life. I mean, that's what you do, most of it.
Yeah.
You know, that prenatal care has been shown to help prevent premature or early births and prevent all sorts of, well, there's the lower rate of infant mortality in that group, right?
Well, I mean, because you're asking questions early on about, you know, do you smoke? So, you know, when I started the Infant Mortality Task Force, I always tell this story about how I asked a patient, we do this, motivational interviewing with patients where you say, what's the benefit of continuing on in the behavior? And I just said to her, I go, well, what do you think smoking does to your baby? And she said, I think it gives them lung cancer. And I mean, you and I know that that's not true, but there's, you know, a disconnect. And so part of what prenatal care does, and I was able to say, well, you know, smoking is it affects how their brain develops and the place in their brain that is important for babies when they do turn over on their stomach, and then their carbon dioxide level increases, and then they need to turn their head to get more oxygen. That part is what's damaged from smoking, and so that's why that interaction with your provider is so important.
What about alcohol in drinking while you're pregnant, or drinking before you know you're pregnant? And then, oh, I'm pregnant, now I should stop, but you're now past that most important phase. But tell us about that, Bonnie.
I mean, drinking during pregnancy has been shown to have significant adverse effects.
On that baby.
Right. And I think anyone who is interested in or thinking of becoming pregnant needs to worry about the whole preconception care, which is now, you know, it's not just prenatal care, but
Prenatal care meaning while you're pregnant.
right,
It's preconception meaning before you get
right.
pregnant.
Get in really good condition. Be doing the right things before you end up getting pregnant.
We talk
yeah.
about in the United States, you know, depending on where you are, 45 to 50% of pregnancies are unplanned. And that very scenario that you're talking about, where you haven't modified your health, your behaviors in order to, you know, provide a good environment for fertilization and implantation and all of those things that are very important, just, you know, that occur over a very few short days. You know, a lot of people get caught.
So, so let's say that the baby is conceived, right? And it's 2 more weeks before the menstrual cycle is missed. And it's missed, so you wait a couple more weeks. So now you're 4 weeks into it before you go, I might be pregnant. Now, when is the most important formative time for the fetus?
So the first 12 weeks are very important. Most of what we call organogenesis, so the formation of the baby, is happening in the first 8 to 9 weeks.
So I mean, you're halfway done
So
by the time you
by
even
the time
think
you
you're
have a positive pregnancy test, you're far into the game. Typically, if the embryo survives at that point, well, it's probably a pretty tough embryo. But at that point, it's still very important. There's still a lot of work that's being done, you know, on a physiologic level. So it's still important to modify those things that you can.
So I looked at early pregnancy. I mean, early birth being preterm delivery. In other words, you're not 40 weeks or 42 weeks like you're supposed to be, but you're 30 weeks. I mean, coming out early and immature, and that occurs in higher rates of younger people. Is that right? Explain that to me.
I don't know if we can.
Why?
Well, I mean, the March of Dimes comes out every year and says that, you know, the preterm delivery rate is just going up and up and up and up. And so we haven't been able to really get a grasp on
Of why it's happening.
It does occur more often in teenagers, but teenagers, a higher percent of them smoke during pregnancy. A higher percent of them are not going to get adequate prenatal care.
A higher percent of them don't go to the dentist and have good dental health. I mean, they're teenagers.
They're teenagers.
Yeah.
And so.
So you don't know if it's really the mother's age that is having this adverse effect. Is it something about her physiology that she's still growing, or is it her lifestyle?
I was looking at the South Dakota Governor's Task Force information, trying to learn about this topic.
It's a lot.
A lot of stuff there. And I saw that before 20, you're at higher risk, and it gets best after 25. I mean, 25 would be your ideal age. Would you say that? I mean, the numbers, statistics say 25 to 30 is that window that's perfect. And then it starts to go to the heck after that, right? Well.
Yeah, I mean.
Not the heck.
Not the heck. Old ladies can still have babies too. I have a 1-year-old and I'm 41. So. But yeah, I mean, certainly we see, you know, that kind of trend. But I think to your point about the numbers, youth is a good thing, but it's also that most 25-year-olds are at a pretty good place in their life where they're living a healthy life as well.
Would encourage timing.
Yep.
But waiting, not doing it at 16.
Planned pregnancies are always a very good thing.
We like that. We have a question from, what is meant by preconception care? Let's say that again. Preconception
care.
Conception meaning?
Before you become pregnant.
Yeah, conception means the baby is born. I mean, the baby is made.
Fertilized.
Fertilized.
Before fertilization. So yeah, that's
before fertilization.
So in my practice, I will have a lot of women will come in for their annuals, and we'll do, you know, a risk factor modification kind of visit to go through blood pressure. Yeah, so they're coming in for their pap smears, but you know, we talk about weight loss and diet, and the most important thing, prenatal vitamins, which are before you get pregnant.
Right. That's that first 4 weeks. You really need a folic acid diet. I mean, isn't that? So let's talk about folic acid. What? I mean, it's just a vitamin. Folate.
That's been shown to reduce significantly spina bifida and other malformations.
Of the nerve system, the nervous system.
And I think we talk about spina bifida, but just for people who aren't, you know, for my kids out there, for younger people who are listening, the spina bifida is when the the spinal cord doesn't close, and so a lot of them can have defects anywhere up and down the spine. And of course, those kids, when they're born, there's some that are just not compatible with life, but there's some that are, and those kids are going to be at risk for SIDS too.
So, have we been successful? I mean, in what realm have we been successful? I mean, have we taught people that they need to take folic acid if they're going to be or if they're pregnant? Or we could do better teaching them to take it before they get pregnant, I suppose. What can we do better on the folic acid story?
Start it earlier. In fact, any woman of childbearing age, no matter if you are contracepting or not, you need to be on a prenatal or a multivitamin that has folic acid supplementation.
And is there a certain dose of folic acid that you think?
400 micrograms. For pregnancy, we say 800 micrograms, so almost a milligram.
Okay. Mitchell, are infants at higher risk if their mother is overweight or obese?
Yeah, I don't want to bring questions down.
They're at increased risk of mortality, yes.
So the mom's being
Obese prior to pregnancy.
Prior to pregnancy.
Carries with it, you know, it's not the weight gain during pregnancy, it's the weight that you had before pregnancy. Mm-hmm. Higher risk of...
But I'll just put a button here that maybe it's also, you know, back to the teenage moms. Is there something about these women that are overweight that puts them at risk that's more important than being overweight or obese?
Something else.
Right. Are they getting enough exercise? Are they smoking?
Right. Well, and then the other side of it, undernourished. You know, we look at malnourishment. Obesity is malnourishment. It's not the right, it's too much. Undernourished, too. I mean, is there a lot of undernourished women at that age? You'd think they're getting enough. Teenagers and 20-year-old women.
Yeah, you know, that's a hard group to kind of wrap my head around because, you know, in the state of South Dakota, women who are pregnant below the age of 18 are not emancipated minors, and so you're doing a lot of like prenatal care through parents and things like that. So they're teenagers are kind of tough nuts to crack, and if I have a skinny kid, I'm like, are you eating? And they're like, yeah, I'm eating. And
but what are, you know,
but they might not be.
Coca-Cola
But they
and
might,
Cheetos, you know what I mean?
I don't know. Yeah.
We are what we eat, and if you're pregnant, your baby is too. The importance of a healthy diet for expectant mothers.
Every single cell, organ, and system inside a newborn baby comes mostly from her mother's food intake, before or during pregnancy. Maternal nutrition is a critical determinant of infant health. Thus, it is important to stress good nutrition starting before conception through delivery. For prevention of neural tube defects, focus on folate. Folate can be found in enriched grains such as cereals and breads, dried beans, asparagus, and spinach. Focus on appropriate weight gain during pregnancy to prevent preterm birth and to promote appropriate fetal growth. Ensure adequate antioxidant intake from beans, berries, and other dark-colored foods to ward off oxidative stress and inflammatory response. Prevent anemia by focusing on a variety of iron sources. Make sure to include both heme iron from lean animal sources and non-heme iron from plant sources such as beans, broccoli, and potatoes. And finally, ensure good control of blood sugars if you have pre-pregnancy diabetes or if you develop gestational diabetes to promote a healthy growing environment for the fetus.
Do you have questions about preconception or prenatal health? Call in with that question at 1-888-376-6225 or email us at questions@oncalltelevision.com. Need your questions. And speaking of questions, well, and thank you, Katy, for that nice little story about the proper things to eat. But you can't get enough folic acid or folate in just food, can you? That's the question my wife and I were bantering about when we were prepare?
You know, we have a lot of folic acid supplementation, but the studies that, I mean, where you look at birth defects this is in addition to what a normal diet would be.
Okay.
So I wouldn't, just the folic, it's just a little tiny pill.
Easy
Little
pill.
Tiny, easy.
Right.
And before you get to those questions,
Yeah.
I'd like to ask a question.
Sure.
Because I was asked to ask a question.
Okay, ready, go.
With the Safe Sleep, you know, the angel monitors?
Yes.
What are angel monitors?
It's a little mat, I think, that goes under the crib,
Right.
correct? And it's essentially an apnea monitor.
Apnea meaning?
Apnea meaning baby stops breathing.
And alarms go off.
And alarms go off.
There's no movement.
Right.
So I'm not a pediatrician. I am a paranoid parent. So I asked my pediatrician about it, and she did not recommend doing that because, and just looking back on my patients that have had preterm deliveries where you do send patients home with apnea monitors, little babies, they tend to overcall it. So
it's trying to be safe.
yeah, it's trying to be safe, but I didn't.
You're not pushing it, but there's a time for it.
But I don't think the American Academy of Pediatrics endorses that.
All the time in every kid. But there's a time for apnea
Well,
monitors.
but there's a difference between an angel monitor, which is that's a commercial
You
product,
can buy it.
versus a durable medical equipment that is prescribed by a neonatologist.
What do you think about angel monitors? You had the question.
Well, it was for someone else, but they had preterm infants, and also my granddaughter. They used a monitor with her, and it seemed like, you know, you go in there and pick her up, and all of a sudden everything starts.
The whistles
Buzzy.
blow and the sirens go.
I know.
And the woo, woo. So I do have
If
another.
it makes parents sleep better.
Or does it? I mean, it seems like if the alarm's going off all the time, it would be making mom
I
and
don't
dad
know.
not sleep better.
I don't know. I personally have like a video monitor, and not everyone can afford that. But if my son started turning over very early, like when he was 3 weeks old, and so my husband and I used to whistle into the monitor, and if he kind of jumped, we knew he was okay. But yeah, I mean, I don't know. But I don't know that the American Academy of Pediatrics endorses that.
As a parent of a 20 to 25, a 28, and a 31-year-old, I'm so glad I'm past those phases of worrying about what they're doing. And
Be a grandparent.
Haven't got any grandchildren yet, but hoping to be a grandparent, and then I'll start worrying again.
And then you can give grandparent advice.
Yeah, I love that. All right, well, I want to talk about prams, because we were looking not only at what the governor's task force on infant death tells us, but we're doing prams now. Tell us about prams, Bonny.
And that actually was one of the recommendations of the task force, was the collection of more data.
Right.
And the PRAMS is something that is the Pregnancy Risk Assessment Monitoring System. The questions were developed at the CDC. It's currently being done in 40 states across the country. It's never been done statewide in South Dakota. In 2007, the Great Plains Tribal Chairman Health Board conducted the tribal PRAMS on all the different reservations, but we've never had a statewide.
So it's a survey that is given to whom?
The mothers completed.
How old? I mean, at what stage?
Oh, so the infants are sampled, and we send out the survey when the infant's about 2 months of age, and we need it back before they're 6 months of
So what
age.
questions does the mother have?
There's questions on there that get at attitudes about pregnancy, behaviors, the drinking, the smoking questions, intendedness of pregnancy. The things that I think are going to be really interesting are barriers, like why, if you didn't start prenatal care early in the first trimester like recommended,
Right.
what was it that stopped you from doing that or prevented you from doing that?
And one of the things that you have said is early on you've seen some data to say that some people are not going to get their prenatal care because they can't get off of work.
Right.
Is that really happening, do you think?
Yeah, well, that's what the tribal PRAMS found.
In
A large
2007 or something.
percent of the American Indian moms could not get off work to get prenatal care, which I think is
Crazy.
just
I mean, it's oof.
depressing or
Well,
uncalled for.
I was listening to NPR today, and they were talking about a lot of, a woman who was working and she was pregnant, and she wanted to bring a water bottle to work, and they wouldn't let her bring a water bottle, and the doctor wrote an excuse, and 2 excuses later, she was fired. And
It's a kind of, I don't want to use the word infuriating, but I will, because everyone wins with prenatal care. It is far cheaper to take care of a pregnant woman. It is far cheaper to let her, and this is where I'm going to get political, but it's cheaper to let her get off of work and take care of herself than it is to pay for an NICU admission. Those are
One ICU?
hundreds, one ICU,
Neonatal.
yeah.
Or a
the
neonatal, what's the
yeah.
cost of a baby?
Well,
Neonate?
hundreds of thousands of dollars.
$1 million
And so
baby. kind of.
everyone wins with prenatal care. And so that's something that, if you work in a place with more than 50 workers, you have FMLA, we can fill that, we fill that.
FMLA is leave.
Family Medical Leave Act, so, but, I would say by and large, most employers are really good, but you do have these outliers, especially in our rural areas, where they do have to travel in, and it's not just an hour off of work, it's not just run down the hall and see your doctor.
It's the afternoon or
it's the
day.
afternoon or an entire day.
Transportation can sometimes be an issue.
Well, I think people who are having problems not getting prenatal care because of employer things, they need to scream bloody murder. I'd call the governor. I mean, because we're addressing this issue in this state, and this is extremely important. I mean, millions of dollars can be saved. Dollars is not the issue. The baby can be
Well,
saved.
and this, Avera is very, our telemedicine is, what we're able to do with telemedicine is incredible. So I'm starting actually a pilot in my office to see what prenatal care looks like from through telemedicine in order to sort of get at that rural population, because we take care of women, especially high-risk women who do need to come in for ultrasound and things like that more frequently. So.
Quickly, car safety. Is there something we should be doing for babies with car safety? I mean, there's these car seat things, right?
Right. I mean, car accidents. Accidents is about one of the top leading causes of death in infants, and car safety is definitely a big one.
So the current recommendations for car safety are rear facing until the age of 2.
So the kids have to be rear facing.
It's killer.
And
I'm
does
not gonna lie.
we did it. We can do it.
killer.
You can do it. Turn them around.
Oh, it's just.
But not in the front seat either, in the back seat.
No, not in the front seat.
They
Rear
scream
facing
bloody
until
murder.
2. You should not, any car seat loses its efficacy if you're putting in padding, if you're putting in extra head things, if there's a head support that comes with the system that you purchase, that's okay. The other thing is that car seats are safer, winter jackets, we all have these big bulky coats, but you can't cinch them down tight enough. So now kids in the car seat without their coats on backwards, so that they can cinch it down nice and tight.
No kidding. It's hard.
Yeah,
It's kind of hard.
It's
with the hood.
hard. Yeah, it's hard. I know it is.
The
but
hood backwards is
I put
kind of...
mine. Yeah, it is. But yeah, car seat safeties.
Does secondhand smoke affect unborn babies?
Yes.
100%.
It also it's very much related to SIDS occurrence.
Very.
The secondhand smoke. And let me throw one other thing out. There's a new area of medicine called epigenetics, and it speaks to that it's more than, that your child survives because, and then, the advantage that the survival brings will go to the next child, and the survival type of a thing. It is the environment that person is in affects the grandchildren. We know that if there was starvation and obesity in Finland in 1912, the grandchildren of those children who starved and then were obese are affected. And so we have to talk to the father who is a part of this teen pregnancy thing and is on meth.
Well, not just teen.
But just in general,
In general, the
Right.
wellness of the dad is almost as important as the wellness of the mother. Maybe that's why the whole thing is dropping, because of the lack of wellness in our fathers.
I think the focus has always been on, maternal health, because again, this epigenetics question is something that's really in its infancy, and as it relates to even reproductive endocrinology, now we're learning more and more that those paternal chromosomes determine,
Right.
of course they determine 50% and how those things communicate. And so, again, a modifiable risk factor for SIDS at least is smoking secondhand smoke. And imagine being a mom who quit smoking in her pregnancy, but now her, dad is still continuing to smoke, and we know third-hand smoke, smoking in the clothing also can affect babies.
Well, and it might be dad and mom smoking before they are pregnant, too. That
Exactly.
affects that child.
Exactly.
Dad and mom before
and
they are
mom.
pregnant. And the chemicals that the dad might be exposed to. There's a ton of things that could be involved that we don't know. That was what the
National
Children's Study was all about. We have a question from Sioux Falls. What difference does prenatal care make in SIDS? I think we've sort of answered that real quickly. It makes a difference.
It makes a difference.
Brookings, what does the research say about death rates between formula-fed and breastfed babies?
I don't think we've compartmentalized that out, have we?
No.
Do we have data?
I
No,
don't think
well,
I mean, everybody promotes it.
the data, we don't have the data in South Dakota to look at that.
Medicaid, does Medicaid cover?
Prams will get us that
Prams
data,
will
though.
get
Prams
that,
will get
yes.
the data.
Yeah.
Yeah.
So what about Medicaid coverage of prenatal care? You deal.
40% of our moms are covered by Medicaid. Everyone wins with prenatal care. I'm not trying, I don't want to get political by any means, but having a healthy pregnancy early on when there's genetic programming going on all the time from day one of conception, everyone wins. So
Whatever we can do to
improve access to prenatal care is,
Do you think access is a problem?
Well,
yes.
if you don't have access to prenatal care, you're going to end up paying for it.
In a NICU,
in a NICU,
or
in
NICU
the
admission.
neonatal
Right.
ICU,
Right.
it would make smart sense.
And you'll pay for it, as you were saying, with the epigenetic, not just now, but you'll be paying for possibly generations to come.
Now, last week I had two allergists on the show, and we were talking about allergies and the importance of breastfeeding, and because breastfeeding exposes that baby to a certain kinds of
Right.
bacteria that you don't get if you're not breastfed, and it's the same story about being C-section versus delivered through the vagina. I mean, they think that going through the vagina is an exposure that we need to have.
Microbiome.
The microbiome.
Yes.
Yeah.
So what do you think? Is that hogwash, or do you go
I
with
think
the?
there's data showing that.
Yeah.
Yeah, we got total agreement.
But let's be honest, breastfeeding is really hard. And I think that there's so much, I'm an advocate for breastfeeding, but sometimes it just doesn't work. And so I don't want people out there to think that their baby's at risk, or that,
Because
you gotta feed your kid. So
Yeah.
if breastfeeding didn't work for whatever reason, all hope is not lost.
Yeah.
Right.
But-
Yeah, because sometimes I think there's also a lot of guilt put on mothers who
Well, like
can't
are we
breastfeed.
doing that tonight?
Can I see that baby right there? I want
Yeah.
that baby. Because I'll
Are
say
you
something. Yeah, this baby.
Okay.
She was breastfed.
This was a breastfed baby.
Yeah.
But I will tell you that when we talk about safe sleeps with moms, the breastfed moms are ones that it's
Sleep
a
with your
culture. The culture is co-bed sharing. Okay, so American Academy of Pediatrics recommends co-sleeping, which is mom and baby in the same room for the first, few months of life.
But there's some danger there.
Well, but
No.
co-sleeping is
In a
in the
crib.
same room, not in the same bed. Then there's bed sharing. And so when you've got a mom who's breastfeeding, and even just like falling asleep with baby, covering up my microphone, on your chest, you're not protecting their little airways. And so when we looked at when one of the statisticians came to talk about some of the research that they've done on SIDS, you see babies that died actually, mom falling asleep like this or dad falling asleep like this. And so what I talk to my breastfeeding moms about is, okay, you may fall asleep breastfeeding your child, so how do you sleep safely? And so one of the things we talk about is, and there's no such thing, I don't think bed sharing is a great idea, but it does happen. So you never want to share a bed with your baby when you've had anything to drink, ever. You never want to breastfeed your baby in a side-lying position with baby to the middle of the bed. You want to do it to the outside of the bed, because if your significant other is in bed with you, they can roll over on baby and smother. You want to clear the bed of all barriers, and then once you do wake up again, put baby back in its own sleep environment.
Right, and we did that.
Yep.
The deal that I had on with our babies is that I would get that baby up when that baby was crying. I would go change that baby, and then I would bring the baby to Mama. Mama.
You're so nice.
What a good dad,
you're
huh?
a good dad.
It made her
I'd
happy.
say good husband.
Good
Hey,
husband.
let me put it this way: when
Yeah.
Mama's happy, everybody's happy.
Yeah. That's
So
nice.
we like that. Well, you know, this is great. This
Yeah.
is important information.
Yep.
We'll be back right after this.
You want your baby to have the best possible start to a healthy life. Using the new Safe Sleep Guidelines can help. Babies sleep safest on their backs, on a firm surface, alone.
My grandchildren, Henry and Stella, are a joy. There's never a dull moment. But at nap time and at bedtime, we make sure that there are no toys, pillows, or blankets with them when they sleep.
Every sleep time counts. Learn more. For baby's sake.
It sounds morbid and unpleasant to study how infants die, but it makes sense to learn how and why bad outcomes occur in order to develop ways to get good outcomes and prevent suffering. To put this in perspective, we estimate that prior to understanding about forceps delivery, clean surgical C-section, the value of clean water, proper hygiene, antibiotics, and vaccinations, we lost something like half the children born before they turned 6, and many of the mothers. By 1911, we know that the U.S. recorded 135 infant deaths per 1,000 live births. That was better. Now, more than 100 years later, the infant death rate is even lower. There are about 2 deaths per 1,000 live births for the countries of Monaco, Japan, and Norway. Not so impressive is that in the U.S., it is at about 6 per 1,000. Right next to Serbia and Poland. Looking at South Dakota, we're 35th in the 50 states, and maybe a little lower now, at about 7 per 1,000, which is about the same as in Chile and Russia. And what is more challenging is that the rate for the South Dakota Indian population is almost twice as high as whites, more than 12 per 1,000, and is the highest rate for Indian populations per state in the country, right there with the worst poverty. Why is the rate so high in the U.S. and especially South Dakota? Experts explain that infant deaths increase when babies are born too early and immature or with malformations, often because mothers are too young, are smoking or drinking alcohol, are not getting enough folic acid vitamins, are over or undernourished, and are not receiving enough prenatal advice and monitoring from a healthcare provider. After delivery, deaths happen because parents lack knowledge of safe baby sleep practices or of enough dad, family, and community support when times get tough. So what can we do better in this state and country in keeping our babies safe? The most important effort should be to nourish, educate, protect, and empower the girl or young woman who will be their mother, and by enhancing her health prior to getting pregnant, which is called preconception care. Dad shouldn't be off the hook, but after all, it's up to Mom. She chooses to protect her future baby by delaying pregnancy until her body is mature enough, by avoiding smoke and alcohol, and by taking vitamins with folic acid, all before pregnancy might happen. And then once pregnant, she should carry through with what is called prenatal care, getting the advice and monitoring of a healthcare professional, all in keeping her baby safe. How can we better empower her? Studying how babies can die will help us keep them safe. This brings us to the end of our show this evening, and I sincerely thank our guests and good friends, Dr. Kim McKay and Dr. Bonny Specker, for helping answer our audience questions this evening. If you would like more information about the Governor's Infant Mortality Task Force, the Tehlula, the Tehlula Foundation, or any of the other websites discussed this evening, please visit oncalltelevision.com. And as often happens on the program, if we didn't answer all your great questions, so please join us now on website at oncalltelevision.com. Click on the After Hours button, view our answers to some of the questions we didn't get to. We'll continue to live on the web in just a few minutes. Another First Lady, Eleanor Roosevelt, had this view of the beginning of life. I think at a child's birth, if a mother could ask a fairy godmother to endow it with the most useful gift, that gift should be curiosity. Until next time, stay healthy out there, people.
Funding for On-Call Television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, Brookings Health System, Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by a generous support of Avera, Brookings Health System, and Fishbeck Financial Corporation.